Hi, Mike Gibson, David Kandzari coming to you live from AHA 2022, and we're talking about the spiral hypertension study. Talk to us about, in general, where are we at in renal denervation? What's the state of the field right now? And then talk to us about spiral.
Thanks, Mike. So since 2014, when we announced the results of the HTN-3, Simplicity HTN-3 study, renal denervation has traveled a very storied path.
Yes.
It's been a device therapy that, like no other, to my knowledge, has been held to a standard, a rigor of 9 sham-controlled randomized clinical trials. And largely, there has been a great deal of consistency across those studies. Even with the Simplicity HTN-3 study, we recently showed that through long-term follow-up, there are durable, sustained reductions. We've shown this in other sham-controlled randomized trials now through 3 years of follow-up. And it sometimes is overlooked because of the focus on blood pressure reduction, but there's been an exceptional safety profile with both intravascular ultrasound and radiofrequency energy delivery for performing renal denervation. And in this context of hypertension being the global cause of death and disability and the opportunity for effective therapies to globally have a public health impact and influence outcome, and recognizing that even small reductions in blood pressure translate to clinically relevant events, we have several sham-controlled randomized trials, as I've introduced, that have demonstrated the success of renal denervation in lowering blood pressure, both in the presence and absence of antihypertensive medications. And the purpose of the SPYRAL HTN-ON study we're presenting today was to explore the effectiveness and safety of renal denervation in the presence of antihypertensive medications, probably a more clinically applicable context, but in a larger population than our earlier pilot study.
And the primary endpoint here was ambulatory blood pressure, rather than that blood pressure during the office visit. Give us a quick recap of why the field has chosen that.
Certainly. We're always, of course, attentive to both ambulatory and office blood pressure reductions with renal denervation, and both systolic and diastolic for that matter as well. But ever since the Simplicity HTN-3 study that relied on the primary endpoint of office blood pressure, for which we see a bit more variability with office blood pressure, ambulatory blood pressure, which is an assessment over a 24-hour period. Put simply, patients wear the cuff that inflates and deflates every 30 minutes during waking hours, every hour during nighttime hours, and we simply average that blood pressure over the 24-hour period. It provides a bit more insightful estimate of the hypertension burden for an individual, and it's a bit less susceptible to variability. But it certainly can be influenced by taking more medicines or not taking medicines, and it certainly is not the goal. It is not without change, because even in studies without medicines, we still see the ABPM over time vary between patients with 3 to 4 millimeters mercury.
So that was your primary endpoint, a 6-month primary endpoint of ambulatory blood pressure. Talk to us a little bit about who these people were. They had to be on 1, 2, or 3 meds for a period of time.
So the SPYRAL HTN-ON study is an extension from our prior on-meds experience, a pilot study showing significant reductions for both ABPM and office blood pressure at 6 months. And the study was performed as a Bayesian analysis that, if permissible, the Bayesian analysis would allow us to use or borrow the data from the 80 patients in addition to a prospective randomized cohort of 257 patients. But as you suggest, the trial enrolled patients with uncontrolled hypertension, prescribed 1 to 3 common antihypertensive medication classes, and then the patients were randomized in a sham-controlled, assessor-blinded 2-to-1 fashion to treatment with renal denervation versus the sham control.
And it was blinded.
It was blinded both from the patient's perspective, and as I shared, for the assessors doing the follow-up, they also were unaware of the patient's treatment status.
And primary endpoint at 6 months, and what did you see?
So to begin with, we saw no differences in the baseline clinical demographics between the patients. They're quite hypertensive individuals. The average blood pressure approximates 163 over 101 in the office setting.
Wow.
The average number of medicines was about 2 per patient. We saw no differences in baseline medication number or medication burden. But interestingly, prior to ascertainment of the primary endpoint at 6 months, we saw the emergence of changes in medication number and medication burden representing medication number, dose, and class. We saw differences emerge that were statistically significant at 3 months and even amplified at 6 months that were higher in the sham control group. And so in that...
So people were taking their patients off the meds in clinic, or patients, were they self-discontinuing? How did it work?
A bit of both.
Okay.
These changes were confirmed by urine and blood testing, so we have very accurate confirmation of adherence by formalized testing. And we see that prescribers see that the patient may be more hypertensive and adding medicines despite a protocol mandate to keep medicines the same. We see patients who might get renal denervation, for instance, and start to take less of their medicines because their blood pressure is better as well. And so we see it going in both directions. So we saw marked shifts in this expansion cohort, this 257 patient population, where, for example, the net change in medications that would favor a blood pressure reduction, in other words, increasing either the medication number or dose and not decreasing the medications, was tenfold higher in the sham control group than the renal denervation group before the 6-month endpoint. So with that background, at 6 months, we showed an absolute reduction in the 24-hour ambulatory blood pressure of 6.5 millimeters mercury, but 4.5 millimeters mercury in the sham control group. And so the difference of about 2 millimeters mercury was not statistically different. On the other hand, at 6 months, office systolic blood pressure still remained significantly in favor of renal denervation therapy. It was a difference of about 10 versus 5 millimeters mercury, an absolute difference of 5 millimeters mercury, and a highly significant p-value.
And what do you make of that? I mean, is that real? Is it, tell us why there might be that difference.
Yes, so I'll share two perspectives on it. One is that specific to this trial, it's not so much that the reductions in blood pressure for ABPM and office blood pressure are discordant from previous successful sham-controlled randomized trials. So what is achieved in this study with renal denervation, a 6.5 ABPM drop, a 10 millimeter systolic drop, is very, very consistent with what we've seen with prior sham-controlled randomized trials that were highly significant. The difference here is what's going on in the sham control group. And I think that there are a number of potential explanations for this. We performed pre-specified exploratory analyses that highlighted that the majority of the expansion cohort population was enrolled during the COVID pandemic. And specifically, we identified from patients enrolled pre-COVID versus during the COVID pandemic, statistically significant differences in ABPM patterns of 24-hour, of daytime, of nighttime ambulatory blood pressure. And this is, of course, not inconsistent with a larger body of trials from iron supplementation to others showing differences in what's going on in the COVID era. Secondly, because the differences as a Bayesian analysis, because the differences in the pilot cohort and the expansion cohort were so different with regard to 6-month blood pressure outcomes, very, very little of the data could be borrowed for the performance of the Bayesian analysis. So the Bayesian primary result essentially represented the results of the expansion cohort. And last, in my view, is maybe most significant is, as I shared, we saw these significant imbalances in medication changes that were disproportionately in favor of the sham control group. And by protocol, it gets a bit complicated, but by protocol, that influences the ABPM more than the office blood pressure.
What's next?
So we have dedicated follow-up for these patients through 3 years, a portion of them through 5 years of follow-up. Already, though, I can share with you a majority of the patients in the sham group have already crossed over at this stage to renal denervation therapy. So we'll have long-term follow-up with these patients. I should also say in this trial, once again, the therapy proved to be very, very safe with a very low rate of procedural adverse events. And now we're moving on to I think this is the last of for this program, the sham-controlled studies. We're moving on to larger surveys of renal denervation in a broader, less selected patient population. So as an example, the AFFIRM trial, so that we understand the safety and effectiveness of this therapy in people with many other coexisting conditions that would have excluded them from the much more rigorous sham-controlled trials.
Will we ever get to a point where we look at clinical outcomes rather than just the surrogate of blood pressure?
I think so. This is a topical discussion, and first, I believe there's no reason to think that the blood pressure reductions achieved with renal denervation wouldn't translate to the same benefit that we've observed with pharmacotherapies. We have to keep in mind and be humbled, too, that most of the antihypertensives that you and I prescribe aren't held to a standard of a mortality benefit. They're approved on blood pressure lowering. But we've also calculated in a forthcoming European Society of Cardiology EAPCI document that if one wanted to do such a trial, and assuming a 20% reduction in major adverse events that corresponds with a 10 millimeter reduction in systolic blood pressure that we see in trials like this and others, the sample size required for 80% statistical power approach about 20,000 patients. So if such a study does or can exist one day, I think it would be hopefully from us pooling data together with other programs and then carefully giving thought to what the control group looks like.
Fascinating. Thanks for joining us today, Dave. Thanks to
Thanks
all
for
of you
having me.
for joining us here live from AHA 2022.